Welcome to the Self-Funded with Spencer podcast. Healthcare is broken, and we aim to fix it one conversation at a time. Hello, good morning, good afternoon, good evening, good or after midnight. I don't know. Do you weirdos listen to the podcast at 3 a.m.? I'm not sure. Whenever you're listening to it, thank you again for joining. Thank you for listening. You're here with Spencer Smith, the host of Self-Funded with Spencer, for episode 46, featuring Mark Testa of Regenexx. Now, Mark actually stuck around with me for a part 2, which will cover fasting. But today, for today's episode 46, we are going to cover bone marrow concentrate, which contains stem cells. Now, that may sound like a mouthful. It is kind of a mouthful, but I have to be very specific. Bone marrow concentrate, which contains stem cells. Probably should turn that into a drinking game. If you're listening every time I say that or Mark says that, take a shot of whiskey, okay, and get really, really drunk. No, I'm kidding. But we want to be very specific about what we're talking about today. It's not just stem cells. It's the bone marrow concentrate, which contains stem cells. And why we're talking about it with Mark Testa of Regenexx is because there's an application here for self-funded employers where the patients, the members on the plan, can use an intermediate step prior to the indication of a surgery. So let's say I've got a back injury. Let's say I've got a knee injury, and I'm talking to my physician, and it looks like I'm on the path to surgery. What if you could do an intermediate step that would have a fixed cost that has a very high success rate for certain musculoskeletal injuries that might be able to prevent that surgery and prevent being cut open or prevent having something fused or taken out of your body? What if we could take a step in between that final result? And that is what Regenexx is focused on. So it could be shoulder injuries, it could be back injuries, some knee injuries. I think a little less so on the hips, what Mark says in this podcast, but it's using this bone marrow concentrate, which contains stem cells, to intervene with somebody that might have chronic pain, some degeneration, even ACL tears. Crazy thing is if it's got less than a centimeter of a tear on an ACL, the stem cells or the bone marrow concentrate, which contains stem cells, can actually regrow an ACL ligament. It's crazy. So Mark Testa of Regenexx is going to talk today about how self-funded employers can use this Regenexx solution to help their members, to help patients on the plan with a shorter step, a less severe step than surgery, with a very, very high success rate on certain, again, musculoskeletal injuries. So I really hope you enjoyed this episode. It was very fun. Mark's also a chiropractor. We got really deep in the weeds on a lot of cool stuff. And then, of course, episode 2, part 2 with Mark Testa, which comes out next week, will be focused specifically on fasting because he and I also went really, really in the weeds on fasting as well. But today, bone marrow concentrate, which contains stem cells. Mark Testa, Regenexx. Enjoy. I bring up the Avett brothers because our CEO is obsessed. You talked about traveling to go see shows. He will go see them wherever he can. He's done the Red Rocks thing quite a bit. But he's even willing to go. I think he's probably even seen them overseas and stuff. He's just obsessed with the Avett brothers. And I couldn't get into him. Like, he'll send me songs, and they have one song that's like Brooklyn, Brooklyn, which is my daughter's name. And so I kind of liked it for that reason. But I just not my jam, man. Just not my jam. Just give me some double bass drums and extreme guitars, and I'm happy. Well, so you wanna kick off the podcast, Mark? Might as well do it. So, Mark Testa, how you doing, sir?
Very good, Spencer.
I appreciate you traveling in, man. We were just talking a little music. Maybe I'll keep that in the intro. I don't know. You're not a metal guy, which I'll let you slide on.
Thank
that.
you. Thank you.
But how you doing? How you doing this morning? You good?
I'm doing great, man. It's been great talking with you. It's nice and green here in Frisco. And it's feeling good.
So first time in Frisco, or have you been here before?
First time in Frisco.
Cool, man. So what do you think so far? I mean, is it everything you hoped for in Texas, or what?
The weather's awesome right now. I know that's going to probably change soon.
Well, so you're in from Denver. I think we should obviously talk about that. I appreciate you traveling. We got to have dinner last night. We got to have coffee this morning. I think you may have been the guest so far that I've hung out with before the most. So we've essentially already recorded a podcast. I just forgot to hit record on it. But I appreciate you spending so much time with me, letting me know you. But let's get into you, right? Let's talk about you. You work for Regenexx. What is your title? Are you EVP?
Executive Vice President,
so you're in the sales.
Sales, B2B sales,
So we'll be talking about, and I want to make sure I get this right, bone marrow marrow concentrate that includes stem cells.
Bone marrow concentrate, which includes stems.
Which? Does that make a difference legally?
Which include.
Oh, okay.
I think maybe grammatically.
That's really, you're just correcting my grammar. But I know we'll be careful about how we position that and when we talk about stem cells. But before we get into the meat of what we're going to do today, let's get to know you, man. We talked a little music, but what's your background, your history, all those things? Tell me about it.
I'm a chiropractor, acupuncturist. Been doing that for 32 years. I know I started when I was like 8. So.
You started, that's what I was going to guess. You're
right.
Yeah,
exactly. Yeah. So, I've had a very awesome career, very different than most chiropractors, working 90% of the time in-house with physicians, primary care, pain management, orthopedic surgeons, and in hospitals. And so I have had a totally different path than most of my colleagues. I got to see the good, the bad, and the ugly of musculoskeletal medicine in the allopathic world. So,
so where did the interest for you for chiropractic medicine come from?
That's a great question. My parents were first-generation Italians born here, so we kind of just took care of ourselves. They were taking vitamins in the 70s. Really? We had a garden, and so we just grew up around this natural medicine, take care of yourselves. And they were general contractors and, originally farmers, celery farmers.
Celery, okay.
Celery. And so, great question. My parents were first-generation Italians born here, so we kind of just took care of ourselves. They were taking vitamins in the 70s. Really? We had a garden, and so we just grew up around this natural medicine, take care of yourselves. And they were general contractors and, originally farmers, celery farmers.
Celery, okay.
Celery. And so we just took care of ourselves naturally. And then I really in 9th grade started working out. I was that 98-pound weakling.
Okay. Did you have you send off for the book of how to gain weight and how to grow muscle?
I sent away for the Charles Atlas workout thing, right? It was in the back of a magazine and it was free. And I got it. Remember, things used to take 6 to 8 weeks to get here. Yeah. I always tell my daughter
Amazon,
that. I'm like, Mimi, 8 weeks.
Yeah.
So, it came and I started working out and it was all push-ups. And I was like, push-ups? I couldn't do one.
Okay.
Anyway, started getting strong, started working out. Of course, you follow this path of like, where is the origin and insertion of the muscle? How does it work? Had anatomy posters and just had this interest in kind of natural medicine from a young age.
Do you think that was that inception point for you? The interest of anatomy itself was through that Charles Atlas book?
Totally.
That's very cool, man.
Yeah.
That's very cool.
Yeah.
So did your body respond to it? Did you get bigger? Did you gain muscle and things like that from it? Or
yeah, I did.
Or just maybe confidence that I'm doing push-ups now, right?
It's a little of both,
yeah.
Right? And then we put a gym in my basement. And we'd spend 2 hours a day working out. I'm sure a lot of it was just BSing with the guys. But, yeah.
So then did that set you on the path, right? Or was there something you studied in high school or when did you actually get into the study of medicine itself? This podcast is brought to you by True Captive Insurance, a premier medical stop-loss captive for employer groups ranging from 25 to 1,000 employees. True Captive believes in healthcare that is personal and insurance that isn't complicated. That's why they take a white glove approach, making it easy for employer groups to transition into a program built specifically for them. Check them out at truecaptive.com. This podcast is sponsored by PlanSight. PlanSight is a technology for employee benefits brokers to more efficiently manage their RFP process for any group size, all funding types, and over 20 benefit lines and point solutions. PlanSight is the only end-to-end RFP technology on the market today. Let's modernize your RFP process together. Check us out at plansight.com.
So we grew up going to chiropractors.
You did? Okay.
Yeah, we did. And osteopaths. Our family doc was an osteopath. He took care of like 3 or 4 generations of our family, but he did manipulation. And I thought everyone had that. And so I remember looking at that point, maybe obviously towards the end of high school, should I be a chiropractor? Because we went to chiropractors. Should I be an MD? And I just liked the natural aspect of things. And so I made my mind up right away. That was the direction I was going to go into.
Is the educational process different? I mean, obviously it is, but is it shorter? Is it longer? Is it just different areas of study? Walk me through what it takes to become a chiropractor.
So I have an undergrad degree. Then I went to chiropractic school. The basic sciences the first 2 years are exactly the same. Basic science, clinical science. We all learn the same stuff, anatomy, physiology, all that. And then our third year, we go in the clinic and start treating patients. where the third year, fourth year physicians, they go to the hospital or they start doing rotations in medicine.
Okay.
So that's where we diverge, but it's all the same at the beginning.
So, and then you come out, what is the process of coming out of school and then going into practice, right? Are you kind of on your own? Was there a pathway? What do you do?
Yeah, you're on your own. Chiropractors as a profession are outside of the circle of healthcare for most people. And, I worked with a chiropractor in Newport Beach. We had a very busy clinic. I became a really good adjuster because our clinic would see 700 people a week. And I'd probably get my hands on 100, 150. And I got good at that. But that didn't fulfill me at all.
Okay.
I wanted more than just that much adjusting. It's very physically draining, mentally draining. Mm-hmm. And so I was like, I wanted to work with MDs. And in 1990, when I got out of school, we were still called quacks, literally to my face.
We had this conversation over coffee, and I didn't want to kind of go to this backstory because I knew there was somewhat of a perception of chiropractors at times, right, that get labeled as such. So what's the origins of being called a quack? Because nobody wants to be called a quack. Obviously, it's not true. But something triggered that, right? The
origin probably started in the 50s or early 60s, where the AMA, the American Medical Association, felt that we were competing on their turf. Okay. Right? Back then, there were only about 25,000 physicians, and there were about 5,000 chiropractors, and people liked natural medicine. They were getting better from a lot of things, particularly musculoskeletal pain. Okay. And the AMA didn't really like that. They started a committee on quackery in 1962 or 64. Look, they also pushed against Medicare, right? So they're trying to protect revenue, turf, and everything.
Well, you say committee on quackery, though. Was that actually the term?
That was the term.
That was the term, okay.
That was the term. And then they promoted a lot of propaganda, unscientific, cultish. They even went as far to say to their members, you can't associate with them, chiropractors. You can't take a referral from them. Mm-hmm. You can't do an x-ray for them. They like shunned us. And yet here we are, over 100 years later.
Well, was there a mindset shift at some point where everybody came around and said, well, either this is propaganda or we don't believe that, it's quackery? What happened that said, okay, now this is an established, period or type of medicine, right?
So there was a time in the 80s, 90s where the chiropractic profession sued the AMA and everyone that was in touch with them, hospital, radiology, physician groups, everyone, for an antitrust lawsuit because they were really trying to, we were licensed in all 50 states, part of Medicare, but they were really trying to, stop our commerce. We eventually won that lawsuit in 1990 or 89, I believe. And that was really an inflection point where it's like, okay, this has been a lot of propaganda. There is science. They go to school. There's lots of research on manipulation. I don't remember the year, but I remember there was more studies on spinal manipulation than there were other treatments for back pain. Okay. And when I lectured to people, I was like, I would talk about manipulation. I was like, let's talk about the procedure, not the profession. Because when you look at the studies on the procedure of manipulation, whether it's an osteopath or a physical therapist doing it, it makes a difference for people's back pain.
But you said it was unique that you were actually operating, or partnering with MDs. So why was that arrangement unique, and how did that actually come about in the first place?
That was, because I was starving.
That's a pretty good motivation, right?
Pre-internet, and I was like, where are all the patients? They're over there with the MDs. I got to figure out a way to bring value to them. Mm-hmm. And so I did that. I would go in there and I'd say, you're not doing any of this. Just give me your failures. I want just your failures, your surgery failures, myofascial pain failures. I will take all your failures. Okay. And they were glad to get rid of them. Yeah. And so I started getting people better because they had never experienced chiropractic. And then I just continued to infiltrate and lecture and, do the things to show that there was evidence and science behind what we were doing.
Well, you told me about that. So you did a lot of lecturing early on too, right? Yeah. I mean, so is this keynote speaking? Is this lecturing at colleges? What type of, what environment were you lecturing?
So mostly, again, pre-internet, it was to the general public in Boulder, where I was practicing at that time, Boulder, Colorado. And, I talked about everything kind of holistic, how to deal with carpal tunnel, how to deal with back pain, whatever. And then eventually I started lecturing to physician groups, nurse case managers, city and county employees, self-funded employers who were looking for ways to do cost savings.
Okay.
And then I got really kind of deep into work comp, which what I really liked about that in Colorado is there's state guidelines that are evidence and community based.
Okay.
The community part of it I really like, because sometimes we do things but there's not a lot of evidence in the literature, but the community's like, oh yeah, this works, I use this. And so that has been my trajectory, is working with physicians, and we bring a ton of value to each other, a ton, because they don't really learn musculoskeletal medicine. I mean, really the honest ones will tell you that.
Well, it's a minimally invasive style of medicine as well, right? So it seems like a natural initial thing to try, right? Chiropractic, whether or not it helps an individual, kind of comes down to a myriad of reasons, but it's a minimally invasive step, right? It's not like you go straight to surgery.
Right.
If you're having a spine issue, let's see if we can get some adjustments or maybe get you in proper alignment, right? Or the geometry of the body and things like that. I wanted to ask you about, though, the actual level of effort, right? That the impact to your body doing adjustments for 30 some odd years, right? It's a difficult thing to sustain over time, isn't it?
It definitely can be. I've definitely had shoulder injuries from adjusting, large people, bad mechanics. I mean, you learn how to use your body correctly if you're going to stay in it, as long as I have. And so,
but you've scaled back. You're still practicing chiropractic, right? But you said a couple days a week now.
A couple half days.
Couple half days.
Yeah,
okay.
right.
Just because you love doing it still, or what's the reason to continue down that path as well?
Yeah, I do like getting my hands on people. I do like educating people. I feel like I bring a lot of value to the physicians that I work with. I can help steer people in better directions. I offer other solutions that otherwise they would never have access to. So I still do that. I always, feel like, this is the year I'm going to quit.
Yeah. And you never quite get there.
I haven't quite gotten there.
Well, I mean, I've used chiropractic medicine myself. I was telling you I had a neck and kind of, I don't know if it was neck or clavicle, but it was going up and causing some headaches. And even it was oddly enough causing, when I was doing bench pressing a couple times in a row over a course of a few weeks, I would get these throbbing headaches, and I'm like, that's clearly not good, but I think it's related to the neck, so let's start there. And got immediate relief after the first episode of care. Continue to do so to ensure that this was sustainable. But I've never been a disbeliever in chiropractic medicine, but that was where I go, oh, clearly it worked for me. I can't say it works for everybody, but in this situation, it was the appropriate step. And I appreciated also that I could just go to a local chiropractor, get in, be seen, be sort of evaluated, and have it addressed immediately too. So that immediacy of relief was obviously a good thing as well. But so if it's not sustainable forever, at least you felt you couldn't go 5 days a week. You said you practiced for 30 or have been practicing still for 32 years. Where do stem cells, now I won't say that's what you do, but where does the idea of stem cells enter into your life?
So, I was at my 20-year point, I was full-time. I was seeing like 30 patients a day, and that was just grinding me down. And I wanted to make a change, but I wanted to remain in healthcare because that's all I know. And so I had an opportunity with Dr. Chris Centeno, the founder of Regenexx. We had worked together and shared patients for about 20 years prior to me leaving full-time practice. And I knew what he was doing, innovating musculoskeletal care using platelet-rich plasma. And he was the first guy in the United States to use bone marrow concentrate, which contains stem cells, to inject into an arthritic knee. And so we knew each other. I was watching him. I had one of my colleagues who had a torn rotator cuff, went to him and got better.
Okay.
And there was an opportunity to start growing our physician network. He was looking for someone. We knew each other. I've always been entrepreneurial and had an opportunity to help build our physician network 12 years ago.
So 12 years ago. And so sales role, right? When you say, when you build that physician network, are you going to these physicians and saying, hey, incorporate this as a potential pathway for treatment, or what is that building of a network look like? So
I would go to conferences, meet physicians. There were a lot of sports medicine guys. I think about some of our early adopters. They were sports medicine doctors, not surgeons, in-office sports medicine, looking for better things. Like Dr. Centeno, like steroids, they don't work that long. They start to actually cause damage. Burning nerves, opiates, that's not very fulfilling to be that kind of a doctor. So there were doctors at that point knowing that platelet-rich plasma, particularly then, and then soon this bone marrow concentrate, we're going to be the wave of musculoskeletal orthopedic care. and started meeting them and talking to them and supporting them. And then they, started working with us, and we started getting geographical coverage around the country. And now we have about 90 sites around the country.
Okay. Well, so you mentioned platelet-rich plasma, PRP.
Correct.
How does that differ from stem cells?
So platelet-rich plasma comes from the blood, and it has growth factors. Platelets have growth factors. And when and we can concentrate those growth factors. When you put them into an injured tissue, those growth factors come out, and they get the local repair cells to work harder longer in that area. And then bone marrow concentrates probably on a higher spectrum of ability to get the local repair cells to work harder longer. But the cool thing is they're also chemical messengers. So they're calling in other cells, ligament, cartilage, bone, tendon, muscle cells to do the repair job. But they can also turn into your brick and mortar. Okay. And so we have published papers on, and see it visibly on MRI where we can see ACLs reconnect or rotator cuff tears reconnect if they're not shredded or separated real far, because the bone marrow concentrate can turn into that tissue.
Well, that was something you said last night that was astonishing to me. And, and we'll go kind of all over the place in terms of, what stem cells is, the extraction process, the bone marrow, which contains stem cells. But that was one of those things as an ex-athlete myself, fortunately never had an ACL tear, but is very, very common in soccer, especially.
Yeah.
So you were saying as long as the ACL is not shredded, meaning it's not completely evaporated or there's other serious ligament injuries to the knee, and that if it wasn't farther than, I think, 1 centimeter apart, so it literally can regrow the attachment. Is that correct? Okay, so how does that work, right?
So I didn't know this, right? We were the first ones to ever inject an ACL. No one ever done that because it was always a surgical repair.
And it was believed, right, that was the only way to repair it.
Exactly. Okay. But apparently there's a sheath around the ligament. And so when you put bone marrow concentrate in there, that sheath just sort of keeps it all in place.
Okay.
And that's when they can call in these other cells but start to turn into your brick and mortar. And I think what they do is they sense the environment and they know what to turn into. They don't turn into cancer cells. They don't do any of that. And we've published a safety paper on this and looked at that, and that just doesn't happen. Okay. But they turn into you.
Well, so why do you have any idea why the 1 centimeter is the threshold in which it, if it's 1.01 centimeters, does it not repair fully, or do we have any speculation as to why that is?
I don't. Okay. Not a good one.
I would say maybe it's just limitations, right, of the science, right? And the science is constantly kind of trial and testing and figuring out what works and didn't work, right, and pivoting.
I use limitations of matter, right? Okay. So matter, who we are, how we are. Like if you drop an egg, the shell's got a limitation to it. So I think it's just a limitation.
But you did say that, obviously if you're an athlete and tears an ACL, this seems like that'd be an interesting opportunity, but there's also, we know how to do ACL surgeries nowadays. There's lots of really good surgeons. Guys come back sometimes 7, 8, 9 months and come back maybe even better than they were before. So they know that process works. But if I'm an athlete or somebody, maybe I'm just a mom or a dad or whatever that have torn my ACL playing basketball on the weekend, like why would you maybe consider this as a first step? So there's a lot of data out there now on the ACL repairs. When they put the graft in, whether it's yours or a cadaver, whether it's a tendon of yours or a cadaver graft, the angle that they put it on in the joint is more steep than the angle of it naturally. Okay. So that automatically starts causing, and anytime you open up a joint, it starts to degenerate. Of course. And so sometimes, the tunnel that they put that into with the screw gets loose, the biomechanics of that joint change. We see a lot of, as to your point, soccer players, kids, teens, who will go down this route first because their parents do this research and they're like, my kid's going to need a knee replacement in 15, 20 years. And, you just can't start doing that at a young age to the body and expect it to continue to last. So, yeah. And did you say at least again, right, they were still early on in the stages of understanding its application with the ACL, but didn't you say there's a shorter recovery period as well versus surgery? Like what does that time frame typically look like? It's about half back to play versus surgery. So 4 months, 5 months, somewhere in that range. Yeah. I mean, that's fascinating to me because as somebody, especially even I've played soccer within the last 20 plus years, even in my lifetime, an ACL injury was almost often a career-ending injury for a lot of people. Now it's turned into a common injury that can be overcome with the right surgeon again and the right rehab. But think the evolution of this could potentially be where there's an application of this concentrate which contains stem cells that could prevent a surgery. I'm going, man, that's almost mind-blowing stuff to me. And again, we're getting into, that's kind of on the cutting edge of that, but let's talk about more common applications of this, right? As we talk about what Regenexx does, we're talking about in the employer space. So could you talk to me why this application for what you guys do does apply to employers, and especially self-funded employers?
Right. So, cost savings, number one, right? An average orthopedic surgery in the United States, whatever that is, I factor in cheap, less expensive carpal tunnel and expensive spine surgery is about $28,000. So when you look at our average cost last year in treating someone, and this is all needle based, and it's in the doctor's office, it was about $6,500. So that's all in for the procedure. There's no anesthesia. There's no facility fee. People get back to work literally in days, not weeks or months. And, medication use is less, rehab is less. And so there's this big upside to cost savings, but also keeping people working. And then I think a lot of people are looking at it as innovative benefit. Right? Something new to offer that can, and then MSK costs run 12 to 15% of the medical spend.
So musculoskeletal, MSK, 12 to 15%.
Right.
Interesting. I believe it though, man. I mean, you think about back injuries, you think about shoulder injuries, neck injuries. I mean, what else kind of fits in that, at least in the workforce, would be applicable in MSK?
Well, really, it's being a human being, workforce or not. So we treat a lot of knees, people on their way for a knee replacement or on that spectrum, meniscus, things like that with knee osteoarthritis. I think the number 2 thing we treat is lumbar spine. I mean, low back pain is the number 1 disability as per World Health Organization around the world. And there's no great treatments for it. I mean, I worked with all the spine docs, steroids, temporary use or benefit, burning nerves. I mean, patients would ask me about that. I was like, it's like your house is on fire and we're going to smash the smoke alarm and expect your pain to go away.
Yeah, exactly.
So that's not a good one. And certainly spine surgeries, is really a roll of the dice.
It is. Okay.
So,
so we're talking about, this, we're on the spectrum or the continuum, I think is the word you used earlier when we were talking on the continuum. Obviously, this is earlier on in the continuum of intervention, right? And relatively low to no downside. But you did say it's investigational, so I want to make sure that we address that. So it is investigational. Why? And what does that mean? Why should somebody maybe not be scared about that terminology?
Right. So that's a term given to us by, and given to us is in general by the insurance carriers, Blue Cross, United, Cigna, Aetna. And to some degree, they have a good point with it. Like, right, there is no data on stem cells for hair growth or erectile dysfunction. And yet there's a lot of people doing this in the cash space. So I see where that comes from. That said, they're not looking at the research, the data, the published literature that goes back into the 90s, the randomized control trials that are now out on all of these things. And there's really not an upside for them, right? There's no facility, there's no hospitalization, there's none of that. So there's that. But we follow very clear guidelines by what I consider a higher authority, which would be FDA. FDA has guardrails that says, right, as long as they're your cells, as long as they're going back into you, as long as they're not more than minimally manipulated, and all we do is concentrate them, and as long as they're used for the musculoskeletal system, a homologous use, then that's allowed. And so we follow that rule. I think the BUCAs are just like lagging behind, but we're going to see this change. And I mentioned this last night, TRICARE, right? The government's military insurance, 9 million covered lives, added PRP for knee osteoarthritis and tennis elbow in 2019. So they're seeing it as well. And we're going to continue to see it. We've worked with Navy SEALs who are on site, God only knows where in the world, who are doing these procedures to Navy SEALs. For the same reasons athletes get it and everyone else wants it. Less invasive, quicker recovery.
Quicker recovery, right? So let's talk about the actual extraction, and then I guess would you call it an injection on the other side? So the extraction and injection process. Walk me through what actually happens to a person.
Okay, so let's start with the platelet procedure, all right? That's a blood draw, just like any other blood draw. We concentrate those cells, which is important because we can concentrate it for, the condition, the body part, the severity, these things. And that matters because what you need at your age will be different than what I need at my age for maybe an ankle versus a knee. So we can do that. The cells are only out of you for a couple hours in the concentration process, and then they go back to the doctor who injects them with a needle under ultrasound guidance or video x-ray, fluoroscopy. So we can target the tissue. It's not got to get close. It's like you got to get it exactly in the tissue that's injured. A bone marrow concentration procedure is sort of a three-step process that we use, where we use a farming analogy where we till the soil, plant the seed, and fertilize. So we till the soil on, let's say, a Monday, where we inject a pro-inflammatory into the area. Remember, inflammation is the first step of healing. Systemic inflammation is bad, but inflammation is the first step of healing. And so we start that process. Day 2, maybe on a Wednesday, we would do a bone marrow extraction. It comes out of the iliac crest. You put your hands on your hip, that's the bone.
So I want to make sure folks that are listening, right? So we're talking about kind of the side or the back of your hip.
Yeah,
right? Okay.
Exactly.
And was that the iliac crest is kind of at the starting point? I'm remembering my anatomy, from my study days, but so kind of that back, lower portion of your back and hip. So you actually go in. And is a needle going into the bone itself and pulling out marrow? Is that correct?
Okay. Yeah. Now that sounds scary.
It a little bit. It does sound a little scary.
I've done it 3 times, twice for research.
Okay.
So I got nothing out of it other than they needed a bone marrow sample, and I wouldn't have done it if it was painful. And I've watched hundreds of these. It's like a 1 to 3 out of 10 pain scale. We're really good at doing that.
How long does it take to extract it?
I think they're maybe in there for, on each side, 5-10 minutes at the most.
Okay.
We do a good job of numbing up the whole area. So
is it just really a slow draw then? I mean, because the marrow is thick, isn't it?
It's got blood cells in it and stuff. So we have a process where we take small amounts from multiple areas.
Okay.
And then that's how you get the most amount of nucleated cells that which contain stem cells to inject back in. So small amounts.
So they've come out. Now what do we do to manipulate?
Now we concentrate those, right?
Then tell me the concentration process. What's that?
So it goes into a centrifuge. We concentrate it, take out, any blood or other cells that we don't want. We want to concentrate the nucleated cells, which, there's a lot of different cells in there. And then those cells go right back to the doctor in a syringe and ready to re-inject, again, under the fluoro or the ultrasound into the damaged tissue.
Okay.
And then the patient goes home. Right.
So what is the setting? Is this what type of facility?
Outpatient doctor's
setting?
clinic.
Okay.
Doctor's clinic, not in an ambulatory.
Have to be a hospital. Okay.
Definitely no hospital, no ambulatory surgery centers, doctor's office.
Okay.
They're all fully equipped.
Well, and that's a way that we can kind of control costs as well as the setting that it's done.
Right.
In, correct. Okay. So the patient goes home. Then what does recovery look like for them?
Well, then they would come back on Friday where we fertilize that now, where we take some of their platelet-rich plasma, inject it in there, and get those cells to continue to work harder and longer.
So it's actually a multi-pronged process.
It is.
So PRP plus the concentrate, which contains stem cells. I'm literally gonna be like a lawyer, making sure I check the box and say it right. So you get both of those things with the procedure itself. Okay, and then so now I've gotten them both. That is the PRP kind of, for lack of a better term, supercharging the cells to do what they do. And then, if I've got, let's pick, what would you say the most common? Knee. So let's pick a knee. What does that recovery look like for me now?
So that's a great question. So you'll have about 24 to 36, maybe 48 hours of stiffness because you're going to get swelling. And that's what those cells are calling more cells in to do. Okay. Start the healing process. So you're going to get swelling. We want it to swell. We don't stop it. Nobody takes non-steroidals afterwards. We manage pain with Tylenol mostly. Okay. So you're stiff. And, there's some discomfort and everyone experiences it differently. Most people leave with a knee unloader brace. Okay. And they just do fine with that. And then you can start weight bearing. You can start doing your thing really right away. And if it's too sore, you're just doing too much.
So you just scale it back a little bit.
You scale it back a little bit. But literally, like by the 3rd or 4th day, that swelling goes down, the pain drops off, And some people start feeling some improvement. Now, that's not the case, but we do see, that's not always the case, I should say. We do see a fairly rapid and about a 15 to 20% improvement in the first 30 days.
Okay.
And we track all that. So I'm confident in saying that because I look at the data all the time. It's on our website if people want to see that.
Okay. And then what about tempering expectations, right? Because you're not saying we're going to come in and fix every ounce of pain you've ever had, and it's obviously got its limitations, physiological limitations, but what are the expectations? When you consider a successful outcome for a knee, what would you consider to be successful? Is it pain reduction? Is it mobility? All of the above? What are those markers?
So we track all those: pain reduction, overall improvement, and function.
Okay.
So these are self-reported by the patient at time 0, 1 month, 3 months, 6 months, and annually, as long as they'll continue answering that questionnaire. And those are the 3 things we look for and track. So yeah, people's function increases, their pain decreases, and they're generally overall happy.
Mm-hmm. But so let's make sure though we temper to the not oversell it, because I always want to be objective in this. You say when you guys are going into the evaluation of a member, there's a kind of a baked-in failure expectation for certain procedures as well. So how often does this not work?
So everyone gets a good, fair, poor candidacy grading first. And in the self-funded space, if you're a poor candidate, you don't even treat them, right? Okay. Surgery is your next step, not us. But if you're a good or fair candidate, we would expect a good result. So knees, very forgiving, do really well. Spine does really, really well when we look at the failure rates. Hips, especially in men over 50, 55 with osteoarthritis, if that's you, we're probably not even going to see you, because we know from our registry data that joint just doesn't respond like the knee.
Okay. So it's obviously not a panacea for everything, right? But so what kind of percentages, rough percentages of an understood kind of failure rate, if you will, for those different parts of the body?
Hip maybe 20, 25, knees 10, spine, when I look at the data, is like single digits.
Single digit failure rate.
Right.
So when you're looking at something, and I'm not trying to position to sell this to people, but it seems like a pretty interesting proposition, right? It's like you understood the failure rate, or at least understood the expected failure rate based on the condition, relatively minimally invasive, right? And then there's the cost element of this, that there is a cost to it, of course, but versus the other options, it seems to be a pretty positive option, at least as a stepping stone before surgery. It doesn't suggest perhaps that all surgeries are going to be avoided, but it does suggest perhaps there's an in-between on that continuum to try this before that, right?
There is a big opportunity in an in-between step. And so when we look at the randomized control trials now that are out, at least on PRP, because there's a lot of them now, it sits at the top of conservative care, meaning that it works better than steroids or Synvisc or physical therapy. It is a new opportunity at the highest point of conservative care before you need to cross a chasm to go to surgery.
That's interesting.
And there was just a great paper out Monday I looked at and just glanced at PRP versus steroid or Synvisc or Hyalgan in the knee, and PRP outperformed those things.
Okay.
So those are sort of the incumbents, but now there's a new
kid on the block.
There's a new kid on the block, exactly, and that's innovation in medicine.
Right, and
that we expect.
Yeah, we do expect it, right? But there's always going to be some skepticism. There's always going to be some resistance. But I do really want to hammer. We talk a lot about self-funding on this podcast. It's called Self-Funded with Spencer. But employer, right? The application of an employer. Who's the right fit? How do you introduce this into a plan? Walk me through the mechanics if you're working through a broker, presumably quite often as well. So walk me through the sales process and the actual application for an employer to potentially benefit from this.
Sure. So we do work largely with brokers, right? They are sort of the trusted advisor for the employer. So we educate them. They can look at analytics and see what the musculoskeletal spend has been, and try to implement this for an alternative solution, right? And so the employers that we work with really are across the spectrum, from white collar insurance agencies who've added it to their own plan because they see the value in it for themselves, to large firefighter trusts, to manufacturing. And across the country, auto dealers. I mean, really, musculoskeletal pain is ubiquitous. And we tend to think it's just people who use their body a lot, but you know, everybody's got some ache or pain somewhere.
Well, you sleep wrong, you sit too long in one position, you know, obviously with our desk jobs, a lot of us, you know, rounded shoulders and neck pain and postural issues. I mean, obviously the application is very broad. So if I'm an employer today, and do I have to be self-funded to introduce
Absolutely have to be self-funded.
You hear that out there? You have to be self-funded. So I'm a self-funded employer, and I say, this Regenexx thing sounds pretty cool. What is the actual execution of adding this to the plan?
So because it's considered an investigation, we have a 2-sentence plan amendment.
Okay.
Goes in there, stop loss mirrors that amendment.
Okay.
And then it costs nothing to add to the plan. We don't have a monthly charge at all.
Okay.
And so we take the initiative to educate everybody. So we send out benefit cards, information to all members. I do educational weekly webinars to educate people. We try to drive people to that through the education, through the benefit card, but we also do a lot of targeted outreach with TPAs, and we get file feeds, and we call, we email, we send postcards. Again, our goal is to let them know they have this benefit, but then they come and get educated. Come to a webinar and learn about it. A lot of employers, probably half, will waive copays and deductibles to incent at least taking a look at this.
Right.
We had one employer who made it a mandatory step before spine or joint replacements.
Oh, really? So you had to do this?
Yes.
Then. Okay.
At least find out if you could avoid those things.
Okay. So then really, is this something that could be done even off renewal cycle? I mean, does it, as long as the plan amendment exists and then the stop loss mirrors that plan document amendment, could you do it off cycle, or does it have to be on renewal?
We can do it off cycle. In fact, we do a lot of them off cycle. And so
how long would that process, if I'm an employer that's doing this maybe because I want to get in front of a specific instance for an employee and we really want to try it and Sally wants to test it out, how long would it take to get us in position to be prepared to go ahead and do that?
So it's interesting. We started working with a city municipality in Pennsylvania, and they said yes, and they had members who were slated for spine surgeries and wanted to see if we could intervene. So we did it as soon as they said yes and agreed that, like, okay, we don't have everything in place as long as you promise to pay it. We saw that patient like within a week.
Okay. I mean, so what the stop loss to mirror it, you tell me, because it's investigational, these aren't going to be spec hits, right? These aren't going to be astronomical claims dollars, but is it just so that it's absorbed into the aggregate pool of claims?
Right.
Okay. All right. Because I'm thinking, you know, I don't know if we want to talk numbers, but it's obviously pales in comparison to most people's spec deductibles. So that's just there as an understanding that this will apply to the aggregate.
Right.
Pool. Okay.
And like I said, our average cost $6,500 last year. Top cost maybe $13,000. For a bone marrow concentrate in the knee. We published the largest safety paper in the world on this, the third of its kind, with 3,000 procedures, 2,700 patients. It's safe. We had 4 adverse events, 0.17%.
And what type? I mean, are they severe adverse events or relatively minimal?
Most of them are pain and swelling at the site.
Which is expected
right?
already.
Nobody turns into cancer. That was, of course, we looked into that. This is the third paper of its kind, so I remind people that's how science works. When one does it, can someone replicate it? And 3 now have shown that it's safe.
Well, so we talked about the history of the chiropractic care, and there was an inflection point. It sounded the antitrust lawsuit was part of that big inflection point where people understood it to be, it works, right? Or at least it's not quackery anymore. Right. Are we nearing an inflection point, you think, with concentrate, which contains stem cells, that the market comes around and adopts it en masse, or are we still kind of far away from that point, you think?
It's coming, right? It's definitely coming. Like I said, TRICARE started with PRP. There's a lot of bone marrow concentrate machines that are available now. Okay. I think it's going to have to be at some point where the carriers remove that.
It's just baked into the plan at that point as a covered procedure?
I think at some point it will be. And it might be 5 more years. You know, Institutes of Medicine said it takes 17 years to go from, science to the clinic.
Okay.
We're at our 18th year and we're seeing this.
So it feels like, again, anecdotes, right? I know people that themselves have received this type of therapy, or maybe slightly different, but still similar with its approach to treatment, and have told me anecdotally that it works, right? I'm curious though, so that we don't get into the quackery, what are some of the things that are sometimes claimed that concentrate that which contain stem cells? People go, oh, it regrows your hair, or does this, and maybe it does, but at least there's not scientific evidence of that. Do you hear some often anecdotal?
A ton of it, right? Everything from Parkinson's to Alzheimer's to COVID was a big one, to, regrowing meniscuses.
Okay.
I mean, that just doesn't happen.
Okay.
When we talk about rotator cuffs and ACLs, that's about the only thing that I'm aware of that will really actually, reconnect itself. And not even in every case. So there's been a lot of egregious claims that have led people astray for sure, and had people spend money that they shouldn't have.
Well, and that's unfortunate, man, but everybody's sometimes looking for that magic pill or that magic injection that'll fix everything. So are there, you mentioned there's particular procedures that aren't appropriate, right? The hip being one that's off and you just say, no, you're a better candidate for surgery. Are there instances with an employer, with the exception of the obvious, fully insured, you're not going to be able to put this in motion, but are there instances where it's just not an appropriate fit, business-wise or otherwise? Or is it really, it just comes down to the individual situation with a patient, determining if that's a fit?
I think it's more down to the individual patient. We only focus on orthopedics. That is our lane. That's where all our research is. We don't go outside of that at all.
Okay.
But for the employer, they just have to be willing to, make these changes. And really, it's their advisor and consultant that really has to carry this water and be supportive, and not be afraid of that term investigational. Really, once we break it down, there's really no water that it holds.
Okay.
Because we've got everything to cross the T's and dot the I's. And like I said, FDA has given us a very clear pathway.
That's awesome. Well, I'm glad to hear it, man. And maybe there'll probably be at some point in my life where I get to test this out on myself. But before we wrap things up, and for those that are listening, I'm sure on the lead-in I'll explain this as well, but we're going to do a part 2. You and I actually bonded over fasting, and the science of fasting, how it works. Somebody that wants to explore it for themselves. I want to go really deep with you on episode 2. But before we do that, the last thing I kind of want to ask you is about the broader future of healthcare, right? You seem to be always kind of on the cutting edge of things based on the history that you described in your backstory. So bigger picture, outside of just the concentrate, which contains stem cells and PRP and those things, is there a next iteration of this that's on the horizon, you think?
Well, for me, I bring my experience of an integrated medical experience, right? I think we need clinically integrated benefits, clinically integrated networks, because I can't tell you how many times we're passing each other at night, right? Like two shifts, right? Like, does this plan have an imaging discount? Does this plan have digital PT? I think we need to build a continuum of, at least from my point of view, musculoskeletal care, where you've got primary care as the quarterback, you've got digital PT if people want to do that at home. If that stops working, you've got what we do with needle-based procedures. If that doesn't work, then there's a good surgical center of excellence, all connected. But we all need to be part of the same plan so that we can all communicate, and we need one hub to communicate out of. I think that's going to be the next better improvement in healthcare and in costs. Yeah. Right? If we can all communicate and work together and know that you do have an imaging benefit that isn't $3,700.
What do you think? Better job of coordinating it to educate and explain to the member, or is it just maybe who do you envision perhaps quarterbacking the coordination of all these different options for an employer?
So maybe a nurse case manager, a care coordinator, somebody who's really got their hands on it, or direct primary care. I mean,
direct primary care.
Yeah. I mean, primary care where I've worked controlled everything. Nothing ever got out of control.
Well, and I'm a big proponent of direct primary care myself, right? It's one of those things that I'm trying to understand the downsides to it, and I haven't found one yet, other than it's sometimes somewhat difficult to scale. I think we were talking about this last night, getting physicians, younger physicians around to the notion that there's another way to actually get paid and to do business, or physicians that have been paid by insurance companies for 20 years to shift towards that direction for a higher quality of life and higher quality of care. So I'm a big proponent of that. Is there a potential coordination with that and what you do, or is it maybe just, hey, they identify a proper patient then to refer to you or something?
I think that's the best, right? They identify them. They've been managing their problem for whatever period of time, and now they need to move to the next step. And I think primary care is the right group to do that.
Well, I appreciate you sitting down with me for part 1. We got your backstory. We talked about chiropractic care. We talked about Regenexx and bone marrow concentrate, which contains stem cells. I'm literally probably going to quote that on the post so I don't get it wrong. But we're going to go get a drink of water, a potty break. Appreciate you guys sticking around for the end of part 1. And next one we're going to do is part 2, and we're going to go deep into the weeds on fasting. So thanks, Mark.
Thanks so much, Spencer.
Appreciate you, man.
Yeah, likewise.
Thank you to our podcast sponsor, True Captive Insurance, a premier medical stop-loss captive for groups of 25 to 1,000. True Captive believes in healthcare that is personal and insurance that isn't complicated. Check them out at truecaptive.com.